And what's really borne out is this is possibly the first time, and in such a global scale, that people have felt their lives might be in danger and they're not in control of their environment.
My name is Xaviour Walker from the Kiwi Leadership Network, and I'm pleased to do another interview on Kiwis and COVID. We're focusing this series on humble Kiwis who are out on the front line, working in the United States in this very difficult time with COVID-19. And I'm very pleased to welcome a dear friend and colleague of mine, Dr. Hermione Hurley. Dr. Hurley is working at Denver Health, and she is originally from New Zealand, engineer by background, and is a graduate of Otago Medical School. She has completed internal medicine training and worked as a hospitalist, and then has gone forth and done a fellowship in infectious diseases and substance abuse, and is triple American board certified. So she's been on the forefront with COVID, and it's great to talk to you today, Herm, about your experiences in Denver. So welcome, it's good to see you.
Good to see you too. The triple board certified thing really just belies how many textbooks I read, really. So but thank you for bringing that out. I appreciate it. So I guess one of the things I should explain is how I'm working in America. And it's a slightly different system to when I was working back in New Zealand. But I started work as an inpatient physician, would have been the equivalent, I guess. And so I did that for a long time in Denver Health. Denver Health is a whole healthcare system that includes both inpatient, a number of outpatient clinics, school-based clinics. We help run some of the emergency services like ambulance. We have a detox center. We have a correctional care ward. We do a lot of work in poisons. So essentially, and we have a public health department within our system as well. So it's what America would call like a safety net hospital system. What that really means is we take as many people as we can, insured, uninsured, documented, undocumented, and our healthcare mission is to try and provide healthcare for all. So I used to work mostly in the hospital, and then as I did more specialty training, I found myself moving into an outpatient situation. Now I work in 2 main outpatient clinics, and then I do some advocacy work across the state as well. So I work in a clinic that provides primary care, a bit like being a GP for people who are living with HIV. So I have a panel of patients who are living with HIV, and I provide ID care for those patients. And then I also run a substance clinic for people living with HIV within that clinic. We have about 1,200 people in the clinic. Then I also, after I did my addiction medicine training, I sort of did that in reverse. So I work in what's called a methadone clinic, an opioid treatment program, but it also has, it's a hub for a hub and spoke model of addiction medicine. So we're a specialty clinic for substances. So we have outpatient groups, therapies, and also a daily dispensing. So unlike in New Zealand where pharmacies provide methadone once it's been prescribed, in our setup we have a clinic where people come and pick up their methadone, and if they go through a number of hoops, we get to a point where we are able to give people takeout doses. So I split my time, or I used to split my time about 50-50 between the 2 clinics. So what has been interesting for me is seeing how widespread community spread of COVID-19 has changed the entire way we practice, has changed the entire regulation of how we provide a controlled substance like methadone, and how we've tried to flatten the curve for both our staff and our patients. Forgive me if I use clients and patients interchangeably. I'm actually internal medicine, infectious disease and addiction medicine, but I'm hired by psychiatrists. So they pay my salary and sort of bring me in. And so I sometimes flip in and out of my kind of pseudo-psychiatry speak. So if I'm saying clients, subconsciously that means I'm talking about people I'm seeing in my substance clinic. And if I'm saying patients, subconsciously I'm probably talking about people I see in the ID clinic. So, Zave, you want me to talk about what it was like to be around for the start of COVID in America?
Absolutely. Did you notice it affecting Denver, Colorado area? And
Yeah, so we were slightly strange. I know in America, a lot of the initial hotspots were on the coasts, but we were an early interior hotspot, mostly because this happened right at ski season. And one of Colorado's enormous industries is skiing. So, in fact, kind of different to other parts where it really started in urban and spread out. For us, travelers were in the mountains, so in the rural, high-end rural places. And so we had our first real cases in the mountains, and then it spread into urban areas. But we were starting to see cases in February, late February, early March, really, was when America started to talk in earnest about it. I remember quite clearly having a conversation with my clinic lead saying, hey, you're going to let people who are feverish and unwell stay at home, right, on sick leave? And that being quite controversial even as the first discussion. So our first discussions, it's hard to talk about America's healthcare system without some context that felt really new to me. For example, I have great healthcare coverage. I work for a healthcare system and I get healthcare from my own hospital. But we have paid time off, and if you are unwell, you have to take sick leave from your paid time off. So we don't have sick leave per se for staff. We have the ability to take leave because you're unwell. So that's, if you stay unwell for a period of time and you run out of leave, then you can apply for unpaid leave called family leave. But that doesn't actually, it means your job can be retained, but it doesn't actually necessarily mean that you maintain your wages. So one of the first things that was immediately concerning for people was, did we actually have the legal right to ask unwell people to stay home if it was going to affect their ability to kind of maintain finances in their family? So that should have been the first warning to me that really some of this was about such a broad social impact above and beyond the disease, but it was how were people going to maintain livelihoods? And we felt that almost immediately, even with health staff. The next thing that I probably should have been aware of and is borne out quite well is fear. I had a colleague in California who was working just south of San Fran, in a lot of the rural areas where a lot of vegetables and fruit is grown in California. And she said that one of the biggest things that was difficult for her almost immediately was the fear from staff and of patients, not knowing what was going to happen. And what's really borne out is this is possibly the first time, and in such a global scale, that people have felt their lives might be in danger and they're not in control of their environment. In quite direct contrast to my clients who are maybe in recovery from heroin or methamphetamine or in, doing harm reduction activities. If I ask my clients, have there ever been a time where you felt like your life was not in your own control and you were concerned? Many of my clients in recovery or who are living with HIV have said, yeah, of course. That was a really common thing for me. But for many people who have never experienced a chronic illness or a chronic condition, this was the first time they've really felt out of control. And that sense of fear and disappointment has been pervasive and kind of crippling. It kind of comes and goes. Like there was a time when we were in shutdown where things slowed down and people felt like things were in control. But as we start to open up again, I get the sense that people are starting to feel a little more fearful again. So that was something that has been really pretty hard, I think. For me, I didn't feel as much fear as I did the kind of weight of expectations. So I think you'd be hard pressed to find any infectious disease doctor in America well, probably the world, who didn't get a lot of phone calls from people. What do I do? What am I trying to help with? How can I kind of get through? Do I have to kind of cancel things? How do I tell my kids that this isn't going to happen? And so, there was a hope that we had some kind of inside knowledge, and that really wasn't the case. So I can actually talk a bit about what we did, but I might have to ask you just to pause this for a second, because you know how I said we get a lot of phone calls? One of my bosses just texting me about a discharge plan of someone. Do you mind if we just put a hold on this? I'll be right back.
Yeah,
okay.
sure.
Okay. All right.
Alrighty. So you tell us about you were talking about the response to COVID, how you, and I'd be interested because you wear a few different hats. I mean, you obviously work for a healthcare provider, you have patients, but also any relationship with the local and state health department. I think that would be quite interesting.
Yeah. So let me do it on levels. So actually what I found, even though there was a lot of change and a lot of things that people had to kind of come to grips with, I was very lucky to work in a clinic and in a healthcare system that rapidly changed methods. So we changed drastically across the entirety of our healthcare system. So before we even had a positive case, we in the methadone clinic, for example, see on average somewhere between 350 and 400 people come in every day to pick up a dose. And actually at times we can have people who are queuing for up to an hour to 2 hours in line. So it can be really quite kind of, well, it's definitely not physical distance, and it's definitely quite, can be quite emotional, and there can be distress there when you're waiting. All that to say, one of the first things we decided was we formed a small subgroup that was multidiscipline. So it had in it our counsellors, our front desk staff, some management, my clinic director, me, leads from therapists. And what we really tried to do there was, and our charge nurse. And what we tried to do was try and set states. You know how I said there was a lot of fear? I tried to generate something that didn't feel fearful. There's a thing in America called an ice cream social, which is where you come and you eat far too much ice cream and you put lots of sprinkles on it. So I called our committee the Ice Cream Social Committee, and we met weekly. And then we set categories for how much response we had to have. So just business as usual, starting screening, trying to find our first cases was vanilla. When we started to find our first clients who had symptoms, even if we couldn't get testing, we called that chocolate chip. Rocky Road was when we actually had a high number of people who were COVID positive, but still had to have some presence in our clinic. How would we do that? And Chunky Monkey was an avoidable state, or one we really wanted to avoid, where in fact other methadone clinics within the state would close, or there was some kind of catastrophic event. Because if that happens, methadone and medicines are essential services. Our patients would have a really high risk of relapse and mortality, and we kind of have an epidemic overlapping with a pandemic. So we anticipated that we had to maintain services that required physical presence. At the same time, we also had to be aware and try and avoid a closure of a methadone clinic, which could send hundreds of people to our clinic in addition, who we never knew, hadn't met before, and that would just, it was a really difficult thing. So we haven't got there yet. We're at Rocky Road, and have been at Rocky Road with a significant number of people who are positive for probably since about late March, getting into April. We expect that we're going to stay at a high level of COVID positivity within our clients for at least a month or two. But we haven't got to Chunky Monkey. All the OTPs are still working. Our needle exchanges are still working. So then we did a lot of physical distancing. So both the state and the federal government made rapid change. So in the past, we were never allowed to do telehealth appointments for medicines that were controlled, like buprenorphine, which is the basis of a buprenorphine naloxone product, which we use a lot in the community. We weren't able to do telehealth and get reimbursed for anyone who was on Medicaid or on Medicare. Medicaid is based on your income level, and Medicare is based on your levels of disability and age. So if we did anything that was actually physically distanced, we couldn't actually get reimbursed. We had very strict amounts of takeouts. Like for methadone dosing, you had to jump through a number of hoops. So if you were starting on a methadone dose in the old world, you had 3 months of daily attendance before you could get your first take-home doses. So some of that was really needed changing as well. So both the federal government and the DEA and the state government Office of Behavioural Health made rapid changes. We had talked to them ahead of time and said we had concerns, and I think they responded pretty fast and pretty well. So we went from having at least a third of our clients come in every day to having only 5 of our 600 clients come in every day, that we were able to liberate doses. And depending on the way we did it as a clinic was we said, depending how far you are into your recovery and sobriety and your proven phase, which demonstrated, whether you'd maintained a period of clean urines and bottle management and returning doses. If you were higher in your phases, you got higher doses. So in the most extreme cases, we went from people who were getting 2 weeks, we got up to 4 weeks of takeout for methadone. But there were almost 180 people in our clinic who previously had been attending either 6 or 7 times a day, who went down to 6 or 7 times a week, who went to 3 times a week. And then we became quite tough and strict on returning bottles, making sure you were doing the right bottles. We had to go from about 5 people who we thought were not able to safely look after their medicines, they had to come each day, to about 20 people now, 2 or 3 months in. But still the majority of people went from getting very strict, low amounts of takeout to the most liberal changes in controlled medicines, probably in America's history of methadone clinics. We do as many intakes as we can on phone now, including for office-based products like buprenorphine products. We still have a reasonable amount of in-person requirements. Most of our counsellors went to telehealth, and we kept almost like a minimal crew in the clinic to deal with crisis, which happens frequently, to deal with people who are homeless and vulnerable and maybe can't get a telephone, and to deal with kind of new starts and takes. But we really reduced the number of people in the building, and we really reduced the number of clients who came. So we went from an average of 300 to 400 people coming through in a weekday to more like 200 people coming in a weekday. We've been really active in trying to monitor these outcomes to see whether people stay engaged, whether there's an increase in overdoses in our community. We have feeds into the state databases and to our local health system databases. We also have been looking with the DPD, the police department, to see whether there's been an increase in diversion. We deal with our ambulance systems to see whether they're having to give more naloxone, the reversal agent. And then we've also followed quite closely who's getting what on what particular days. We instituted physical distancing, so some tape on the ground. We got masks and temperature screening from the start of March for all staff. Actually, screening staff was really important. Staff were actually the first people within our healthcare system to get sick. Then the clients who were stable enough to get prescriptions, and just recently we're starting to see it's moved more into people who are homeless and vulnerable. So for us, the vulnerability rolled downhill. It was just in the last couple of weeks that we actually found our most vulnerable clients were getting unwell. We've got masks for staff. We only have access to paper masks. We weren't able to get gowns. We've got some screens that people can use in terms of face screens, but we've had to limit that. We didn't have enough of those. We had to keep a lot of that for the inpatient services. I got 500 donated masks from the community. People hand-sewed masks. So we got 500 of those. My hospital system laundered them. So we've been giving reusable masks to our clients in the past couple of weeks. And we've been really trying to support that in that way. So that's some of the things that have happened. Some of this may not go backwards. We may not actually be back into a place where we ask people to come every day, but we have to prove that. We have to prove that we haven't done harm. but it has been scary. When we first made these changes, I couldn't tell whether actually my clients were going to overdose before they got infected. That doesn't seem to be the case right now, but that was a very real possibility as we basically changed the entire way we operated within a couple of weeks. We've maintained the same amount of encounters. My ID clinic is down to 50% of the number of appointments they had. In psychiatry, in our substance clinic, even though we moved to telehealth and a lot of our people may not have a telephone, we've maintained the same amount of encounters. It's just that we went from nothing over the phone to 60% over the phone. Intakes still feel better in person. There's something about people looking at you in the eye. But we can't do an intake for someone who's positive. We'll give them care, we'll start them on substance treatment, but generally we might start on a buprenorphine product if we had to, if they're positive for COVID and we never met them before, and then if we transfer them to methadone when they meet us and they're out of their infection period, we can. We've found people who are unwell. We initially started with only clinical criteria. We didn't have access to testing for our clients. It took us a while to get access for our staff. We do drive-through access now for our staff for about a couple of months. It's been about a month that I've been able to get my non-hospitalized patients and clients tested. And that has been helpful. There's an increase in the number of people, but we maintained like a people with symptoms list. And then when we got testing, we tried to increase it, the testing pretty rapidly. So I can usually get a result the next day if someone agrees to a test. A lot of my clients have untreated mental illness, so they find getting tested pretty stigmatizing and scary, so not everyone will go through with a nasal swab. Once they're getting tested, if it's negative and we're pretty sure it's a false negative, a true negative, not a false negative, then we can let people back in the building. But we've set up outside canopies and tents where we'll try and do screening, intakes, and we deliver to the door for walk-up clients, and we deliver to the car for methadone clients to try and minimize the amount of time they come in the building. So it's kind of changed everything. I think we were successful in flattening our curve, but we're not hermetically sealed from the rest of the world. So we're starting to see our clients in particular getting unwell now. Did you want me to talk about the state stuff a little bit, Xav?
Sure. I just had a quick question in between. A lot of your patients you serve are very vulnerable in terms of their housing situation. So I was just interested in terms of issues with COVID going through the homeless population, maybe shelters.
Yes.
And also you must have some. Maybe your colleagues in the jail system. I'd be interested in that, and then we can maybe talk about the state response. And I think also what would be interesting for a lot of people is to know the difference between the local, state, and maybe federal response, because I think especially people in New Zealand, it's quite different. So I think maybe we'll start with the concern with the housing situation in areas where people are vulnerable.
Yeah. As with a lot of American cities, there are a significant number of individuals who are what we call housing vulnerable, or not everyone identifies as homeless, but certainly don't have somewhere that they could rely on for housing. And a lot of, even if they were staying with sort of friends and family intermittently, that became a lot more difficult when people started to isolate. Really, that was not coming and going from the street and coming back to a family member's house just became almost immediately not okay. So many people found that even if they'd had some vulnerable housing or sofa surfing that they could maintain with friends and family, that abruptly stopped. When this started in Colorado, we were still getting quite significant snows. Our worst season for living on the streets is when it's not just cold, but it's cold and wet. And that's sort of over March and April. We get quite a lot of, I've seen trench foot here. We get a lot of frostbite. And if you can't actually maintain feet care, we do a reasonable amount of podiatry in the early spring where people are losing toes and limbs. So sometimes people use shelter systems for intermittently. They don't always go to a shelter. It was very hard for the shelters that are a little popular at that time of year, to say the least, to actually cope with an influx of people coming in. But also, my clients felt that they were really unsafe in a shelter system where there can be hundreds and hundreds of people sleeping on mattresses. So it's really hard to physically distance in that environment. So many people actually tried to avoid shelters over a period of time that was actually pretty difficult for them because it was cold and wet. So what you see instead is a significant number of people I live right downtown. I like living downtown. But in my neighborhood, in any given direction within a block or two, there will be people camping on the side of the road, on the streets, on the city streets. So I think I walked 5 or 6 blocks to the mechanic just yesterday. On the way back, I probably saw 40 tents with people living in a tent on an urban street. The city of Denver has set up some mobile toilets because many of my clients would normally say use a fast food restaurant like McDonald's or a supermarket to be able to go and shower or wash their hands. So none of that's available. So we had to set up some outdoor hand washing stations. The snow is kind of stopped, which is really great. And I would say that the police department is trying hard to keep things that under control and sanitary, but not just sweep the streets of tents, which in the past has happened, like actually moving people on. The shelters started some screening. There's very early days to say what kind of prevalence we have in a shelter. I saw one very early study that was taken last week where they sampled 50 people out of a men's shelter. Of the 50, 27% were positive for COVID, PCR, but only 2 of those individuals, so 14 individuals positive, only 2 of them had symptoms. So it is incredibly likely that our spread is amongst people who are asymptomatic. That's assuming where people are at. I mean, it's the thought that you can have a PCR detectable virus in your swab. We're still trying to work out what that means in terms of the natural history of COVID. Does that actually mean you have a viable virus? For many of our people who were positive, we used to have a 7-day rule before you could come back. So 7 days in the last 3 without a fever. We're finding that it's more likely that it's like 9 or 10 days now. We've just extended that rule. So we're trying to make provision for at least 2 weeks before people return to an in-building facility. The city and council America makes huge buildings, just huge buildings. So what we haven't found is that our hospital systems are overloaded just yet in the urban area, but our shelter systems are. So we have some really amazing partners who provide care to vulnerable people and have mobile units. And so they and the public health in the city of Denver opened up some of the huge event centers. So there's something called the National Western Stock Show where we normally have just a big, like the hugest AMP show. It's just enormous, filled with animals. So they have taken that over as a men's shelter where there's screening on intake so that people can physically distance. Most of the shelters normally ask people to leave during the day. You can't stay there, but this is a shelter where you can stay. There's another one for women, which is equally large. It's called the Coliseum, and it's big. And then they have what they call activated respite shelters, which are effectively some motels downtown where where someone who is COVID positive or awaiting a screen to rule out an infection will stay in a single motel and they can get some medical care there. But my graver concern is that many people don't trust those systems. So it's really hard for my clients to go and get drainage of an abscess from injection to actually go and be seen if they have chest pain. So as well as all the COVID positive things that are going on, we're seeing an uptick in psychiatric need, an untreated chronic illness, and an untreated acute illness because people are concerned about getting to the healthcare system. Then you asked about the prisons and jails. So justice and health overlap in a lot of ways. And sometimes it's hard to see into justice, but I have had two very clear things that I think are encouraging and concerning. If shelters are busy, jails and prisons are very busy. And so before this happened, general population would be people in bunks and sometimes being, a lot of people in dorm room equivalents. So they didn't necessarily have the secure facilities to be able to distance people. There's a lot of work going on to try and essentially decarcerate by not actually incarcerating people for non-violent or drug offenses. There hasn't in Colorado been change in policy, but there's certainly been some sort of decrease in action. So in our local county jail, which is run by the city and county of Denver, there has been a real decrease in the number of people who are actually put into a bricks and mortar jail awaiting a sentence. The prisons have really increased the number of people who are being seen by the parole board. So the parole board is seeing not just people who are due for parole, but equally they had some more rapid move to decarcerate people who met criteria for medical vulnerability. So there are almost 700 people who met criteria by diabetes, age, dialysis, oxygenation, and they are being brought to the parole board in just massive amounts of numbers, so almost a 300 to 400% increase in the number of people who are being released to community. And sometimes because those jails and prisons are concerned they're going to run out of their own pharmaceuticals, they're not being released with a significant amount of medicines. I was already enrolled in a group that was trying to link individuals who are coming out of prison and maybe reaching a community insurance, a health insurance with Medicaid for the first time. We're a Medicaid expansion site under the Affordable Care Act, but many individuals were in prison and have never had health care before. So we'd got to the point where we could get 80% of people linked up with insurance for the day they were leaving. But for people who are leaving now, there are higher amounts of people on something called Medicare. And Medicare is the one when you have disability or age, and that's harder to get linked up. So we're seeing vulnerable people coming out, which is good, and high rates of release for people who are eligible for a release to try and space within a prison system to be able to physically distance. In Colorado, at least, they're prioritizing prison and jails for screening. They've done a couple of surveillance situations to try and screen whole prisons. And again, they're seeing high rates of prevalence, even if people are asymptomatic. So we don't feel like we're past the worst of it. Other institutions that are concerning for us are residential substance facilities, where you stay for about 30 days. So there's a high need for new service as well as maintaining old services, but it's hard for those residential facilities who frequently don't have any medical backup necessarily. They have psychiatry and therapy, but they don't know when to let people back into their communities. And nursing facilities, we're seeing that due to medical vulnerability, sort of being stationary in a small area, that nursing facilities are also hotspots. So those are kind of the things that are going on. But federal, state, and local is just, it's really, I keep staying in America and I keep thinking I understand it, and then I keep not understanding it. But what I would say is that there are things you can do at every single level. I have felt very lucky to be in a healthcare system and in a city that has tried to be proactive. But what it feels like to be in a lockdown in New Zealand is different to what it feels to be like in a lockdown here. Even when we were in sort of full lockdown, which is due to release a little bit in the city of Denver yesterday, still a lot of people outside, still a lot of people exercising, not a lot of masks. Mask wearing's become more prominent now. So that might happen there. At the state level, I'm part of a group where we're talking about crisis standards of care for behavioral health. So for psychiatry, for substance, for corrections. And at a federal level, well, it's kind of complicated. It's a mixed bag. And where I see the most consistent action, even if it feels complicated, is probably on local and state levels. But how it feels to be in Colorado is quite different to how it feels to be in New York or how it feels to be in Mississippi.
Yeah, it's very interesting. Thank you for all those interesting insights and information. Can you tell us about, you mentioned about some areas that actually there may even be some improvements. I mean, do you have areas where you think that actually, the way we're delivering health might actually be beneficial, that you may not go back? Or
some things, some of this feels like a one-way door, like especially for outpatient. It's unlikely we will ever return to where we were before. But what's hard to tell, and we're trying to gather evidence about this as we go, I like metaphors. Some of them are cheesy, but the metaphor I have for this is we are just, feels like we've been pushing as hard and as fast as we can forward. And some of the things we're doing, we're probably just in a revolving door. We'll push as hard as we go and we'll end up just straight back where we started. But other things we're pushing forward and we're never going back. Being able to be reimbursed for telehealth is probably something that was long overdue. There is still value in being able to do some in-person interactions, obviously. And it's hard to do a physical exam. But for things like some substance work, I've found that for clients who maybe have mobility difficulties or are struggling to get into the clinic or find coming to the clinic pretty triggering, because we can have people who are very early in their recovering, and that can be hard to walk amongst people who might be in like an immediate crisis or when you've actually been someone who's been in recovery for a couple of years. So for certain people, telehealth is great. My show rate has probably improved since I've been doing telehealth. I think that if we can continue to monitor and show that there's not harm from liberating doses of methadone, that might be something which allows people to maintain an engagement and stay in substance services longer. It's a big ask. It takes, we haven't been promised that we will be able to keep more liberal doses of methadone. We think we've been very active in collecting data to try and see whether we were causing harm or not. Thus far, it seems no, but there's some subtleties in that. Not everyone manages increased takeout, so you have to try and work out which factors may predispose someone to do well or not so well. I think that it has been a difficult time for patients' voices to be heard, but I think the understanding that neglecting social determinants of health like housing is something that we do at a community peril. I mean, that seems pretty obvious when you come from a system where everyone is thought eligible to have health and eligible to have housing, but that is certainly not a given in parts of America. But that comes at a cost, and I think that cost has become pretty clear. And we are, everyone's an ID doctor now. I'm an epidemiologist. I expect, I don't know how I'm going to get vaccines out to all my clients, but I hope that this may improve my chances of being able to promote vaccines for hepatitis A, hepatitis B, pneumococcal, HPV. So I think everyone in psychiatry would start pop-up clinics for vaccination, but we're already starting to say, hey, I want my vaccination clinic back. We're going to need this. My gravest concern is that we will still have circulating COVID come fall. I think that's likely. We haven't got enough immunity into our communities to have herd immunity. We think we're sort of still probably, I don't know, depending on what the asymptomatic work flushes out. But it's unlikely that we're much above 10%, maybe a little less of community exposure and survival. And, we're probably going to need more like 70% to have herd immunity or vaccination. So it's likely that we will be in a situation come fall where the weather is getting colder, where camping out in a tent is harder again. and where I still won't have a vaccination and we'll have some overlap with influenza. So that's my big worry. But in terms of the positives, I've got more people who feel very engaged in care. Many of my clients actually do well. They've got a lot of resilience they're calling upon. Got good rates of tobacco cessation these days in a group of people who really have really high rates of tobacco use. And I think the ability to provide care in a variety of different ways and be more flexible in how we provide care for my clients with substance use disorder may ultimately be helpful for the epidemic.
Well, that's great. Well, thank you so much for your time, Herm. Really appreciate all the work that you and your colleagues are doing with such vulnerable populations, and I know you're making a difference. And
well, I hope I am, Xav. Sometimes it's hard to tell. It's a big place. Yeah.
And we wish you all the best, and stay safe in Denver, and look forward to catching you soon.
See ya.
Okay, thanks.